Hi, this is Mark Newman from Precision Analytical, and I wrote a blog on a topic and wanted to make a video to kind of explain some of the data that we are exploring in this. This is related to a topic that I have done quite a lot on and really have enjoyed kind of trying to pick through the data to figure out what makes the most sense. And then I've relayed a lot of that information to you, and that relates to the topic of transdermal hormones. There's been this confusion in the marketplace for a long time now in our industry to say, okay, when we look at something like testosterone and we look at values in a man, the correlation between saliva, urine, and serum is pretty good, right? Then we start taking hormones, right? So in some situations, you take a hormone, you can see it reasonably similarly in saliva, serum, and urine. But with creams and gels, what's been seen for a long time is that the response in saliva is dramatically different than what's going on in serum or urine. And what I've done in the past is really dug through the data, especially for men, to say, okay, which clinical data correlates? Does the clinical data correlate better with the serum response or the saliva response? We've got a pretty clear answer, and I'll go through that just briefly here at the end. But I wanted to take a different angle on it here and say, okay, let's look at the female data, because it creates this interesting opportunity to examine this question. And when I did that, for me, it was really like a nail in the coffin of this idea that what's going on in saliva in any way correlates with what's going on clinically. So let me show you what we're talking about here. Okay, let's start with serum. So here's a study where they looked at men. In this case, these men that aren't on therapy actually are taking anti-androgen therapy. So they're knocking down all of the testosterone production in these men and then giving them back transdermal testosterone. And you can see that the values in serum go up in a linear dose-dependent manner. Now, when you take men on testosterone therapy in saliva, this is not a study at all. This is just clinical data from hundreds and hundreds of patients who take different dosages of transdermal testosterone therapy and then test in saliva. And what you can see is if you just compare a common dose like 50 milligrams, you can see this dichotomy that I'm referring to, right? 50 milligrams for an average man puts their salivary values about 10 times what a normal healthy man would be, which gives you the message that, oh my goodness, that's an awful lot of testosterone for a man. Right? Whereas when you look in serum, and urine would give a very similar response here, you see that 50 milligrams has just lifted them up into the normal range, and in most men is by no means too much testosterone. So obviously this is the question, well, which one's right? So I thought it'd be an interesting question to say, well, in men, maybe it's a little more ambiguous, maybe it's hard to study, but if we can take a dose of say 5, 10, 20 milligrams of testosterone, and if the saliva value is implying that it's too much for men, what happens when we give that dose to a woman? I mean, think of an injection. If you take an injection that's really aggressive for a man, right? Maybe too much, maybe you debate whether it's too much or not. And you turn and give that dose to a testosterone deficient woman, right? You're not going to have clinical success, right? You're going to have way, way, way too much testosterone. So it creates this perfect little opportunity to study that. So that's exactly what we did. So we went in and looked at all the studies where they're using these dosages in women transdermally to see, well, what's happening with these women. Okay, before I get to that, let me show you what a study would look like when you're using too much testosterone to treat testosterone deficient women. So in this study, which is a very old study, but it just makes for a nice example, they gave testosterone injections and they overdid it. Patients reported significant increase in facial hair, body hair. They even had clitoral enlargement, so clearly too much testosterone. What happened to their serum? It went up above the normal range. Now, this is with injections, right? But just shows you that's what it's going to look like if you give too much testosterone to women. And that's by no means the type of dose you give a man. That's just a little aggressive for a woman, right? So the question there in red is, when they use 5 to 20 milligrams of transdermal testosterone in female patients, do you get these similar symptoms of too much testosterone? Now, if you want to look at an example of what might happen when you give really big doses to females, looking in the literature for treatments related to transsexual individuals is actually very instructive. Okay, so here they're looking at female to male transitions. they took a typical male dose of an injection or a typical pellet injection or 50 milligrams of a gel. And what happened? The serum levels increased from a female norm, this is with the gels, of 45 up to a male norm, right? And what happened? They got the type of clinical manifestations that in this case they were attempting to get, right? Serum levels for patients using injections and pellets saw similar increases with similar clinical responses. So when you use enough of a gel, you can get those types of symptoms, right? So then again, brings up this question, okay, what happened? What about in this study, if instead of using 50 milligrams, if they had only used 5 or 10 or 20, because the saliva results would imply that that's too much testosterone for a man. So we know if we give those to a woman, you're going to get lots and lots of symptoms of facial hair growth and those types of things. Here are the studies. I think this is fairly exhaustive. This is early 2021. I spent a lot of time, had several people digging through the literature. Send me any paper you can where they're looking at transdermal testosterone in this dosage range. So if you have a study that you don't see here, I'd really be interested to see it. But what we have here is 10 milligrams of a cream, 50 milligrams gel weekly, okay, 3 to 9 milligrams of a testosterone spray, 10 milligrams testosterone cream, again, the cream, 12.5 milligrams, you can see in the Kim study there, that's actually, I think, androgel, and then 10 to 30 milligrams of a gel, and again, one more at 12.5 milligrams of a gel. So we've got gels, we've got creams, we've got sprays, and guess what? None of these studies reported excess androgen symptoms. And these are not unsophisticated studies, but they're doing standardized evaluation of androgen excess. So here's the study where they used a relatively high dose, so I'll quote them. No statistically significant differences between treatment arms for what? Acne, voice deepening, abnormal hair loss or hair growth, right? They're not seeing any symptoms of excess androgen using these doses around 10 milligrams, right? That's really significant in this debate, if there still is a debate, to figure out which testing modality is useful for monitoring transdermal creams and gels. Now, I myself was pretty confused by this for quite a long time. So you can go back and find lectures from me in 2009 saying things like this. When hormones are delivered through the skin by gel or cream, saliva best represents the tissue hormone uptake. Now, if you ask me again today, I would say, no, it doesn't, right? Because I've spent years digging through the data, both men and women, and testosterone and estradiol and progesterone, and looking at all the data that we can find and asking the question, what does the clinical data say, right? If we want to know which is correct, we can't just look at lab values or whatever. We've got to overlay that with the clinical data. Now, just to bring you up to speed as much as I can, this is the most recently published data. This is from a non-peer-reviewed publication in the Townsend Letter, but it's very, very current, right, from this year, showing saliva values at different doses of testosterone. And I show you this to say that the data itself is not disputed. There is not a controversy over what happens in saliva and what happens in serum or urine when you take something like transdermal testosterone. Everyone pretty well agrees that saliva is going to go up really high. Look at the data here. This is a different data set, but this is 5 to 20 milligrams in men, and the average value is about 300. Now, keep in mind, that's probably 12 to 24 hours or 24 hours after therapy, meaning that value is going to be a lot higher at 6 hours, at 8 hours, at 10 hours, and then it's going to come down to what? 310. Well, that value is still well above a healthy, normal male, right? So that's the dose that we wanted to look at to say, okay, if it's too much testosterone for a man, let's give it to a female. Now, I bring up this data for one additional point, and that is this, and that is to say the only place where you'll find that testosterone increases somewhat similarly to saliva. We've looked at muscle mass, we've looked at bone, we've looked at brain, we've looked at various tissues and clinical responses. You don't see it anywhere. The only place you see it is in dried blood spot. So capillary blood, for whatever reason, also shows this similar increase. So again, 5 to 20 milligrams in a man takes you up to around 1200. That's the top of the range, right? So again, is that too much testosterone for a man? We could debate that. But again, if it's debatably too much for a man and we give it to a woman, we should certainly expect to see symptoms of excess testosterone. So saliva and dried blood spot, again, correlate to serum reasonably well when there's no therapy. But when you take creams and gels, they show an exaggerated response that doesn't seem to have any clinical utility. Again, a 10-fold increase over what you see in serum or urine. This all started way back in the early 2000s with progesterone, and noting that when you look at serum with 30 milligrams, you don't get anywhere close to a luteal norm, right? But with saliva, where do you think the luteal range is on here? It's way down here, right? So there's something weird going on here, because this implies that you're taking a physiological dose and you're getting a super physiological response in saliva. So that we've really got to think our way through this, as opposed to just accepting the fact that, well, hormones in saliva are free, so that makes a lot of sense for us to assume that that's what's going on in the tissue. It's not behaving as a tissue surrogate. The data is pretty clear on that now. What else is clear is that when you're asking questions about this topic, you have to think about progesterone separately from testosterone and estradiol. Because look at the progesterone data from the literature. All these studies where they're using 20 and 30 and 40 and up to 80 milligrams, does it ever get into the normal range? No. Does it go up in a linear dose-dependent manner? No. Look what happens when we overlay testosterone with that. They behave differently. Progesterone being so lipophilic, it behaves differently. So we have to think about these separately, and testosterone needs to stand on its own in terms of what testing represents it, is representing the clinical response well. And guess what? There's a lot of clinical data out there, right? And in previous videos, I won't go into detail, but if you look at any of these studies, they will show a clear parallel, not with saliva, but more with serum. With erythrocytosis, it goes up when you take too much testosterone, right? So if you take 50 milligrams and say, okay, what happens with erythrocytosis? Well, that's been studied. So has LH suppression. When you take testosterone at 50 milligrams, the LH just comes down a little bit, right? But if 50 milligrams puts you 10 times a normal man, the LH would go to 0, the erythrocytosis would be going crazy. It doesn't happen, right? The bone mineral density, I will note that Finkelstein study is new on my list. I just discovered that one. And what they concluded is when you're looking at bone mineral density, the group that was on 25 milligrams of transdermal testosterone did not show statistically significant increase in bone mineral density. But with 50 milligrams, they did, right? So is that too much testosterone? No, we're just getting into that range where it's actually working, right? Additional studies that, again, tell that same story. So what's going on? So my theory would be this: the fat-soluble hormones from HRT are concentrated in saliva, right? One of the ways that we kind of know that is that if you put the hormone really close to your saliva gland, right, like on your neck by your collarbone, the saliva value will be dramatically higher than if you put it somewhere further away from the saliva gland. I'll show you a model of what I think is going on there, but it's most extreme for the most fat-soluble. So progesterone, the saliva values go even higher and the serum doesn't go up at all. As you get less lipophilic, that dichotomy lessens. And salivary values, as I've said, don't seem to represent tissue uptake. So here's what I think is going on. Here's what we're trying to do. Take hormone, drive it through the skin, right, into systemic circulation, and then the serum, the saliva, and the urine gets their fair share. Right, so the free hormone can't get into urine until it goes to the liver and gets conjugated. Now it's more water soluble. That water soluble form finds its way into urine. In the serum, you see the protein bound form, and in saliva, you see the free form. So a representative amount in each of the three in their respective forms. That's what we expect to see. But in addition to that, what we seem to see, or this is how the model speaks most clearly to me, is what the data says is that fat-soluble hormones, maybe it's subcutaneous fat, maybe it's lymphatic transport, but somehow it's diffusing into the saliva gland without getting into systemic circulation, right? Take for example, the case of transdermal progesterone that's been shown to be still in the saliva of a woman taking topical progesterone for 5-6 months after she stopped therapy. So that fat-soluble hormone is somehow getting sequestered by the saliva gland. We don't know the mechanism, but what we do know is it doesn't seem to be getting everywhere because we don't see the clinical response. So that model speaks to me about why we see this dichotomy. Why do we see these big saliva numbers, yet we don't see it in the clinical response? So what do we do? My perspective would say for transdermal testosterone, for reasons I didn't really get into in this video, I think a serum will always be primary for testosterone. There are some caveats to using urine testing with testosterone. You get the advantage of having a 24-hour value, right? So if you give a transdermal hormone, it's going to go up and down a little bit throughout the day. So capturing more of that for a urine sample can be a good idea, but the testosterone value itself, I think, is more reliable in serum. But with urine, you're going to get metabolites, you're going to get the estrogen and the metabolites, and a really nice picture of cortisol. So I think that's a good secondary or complementary tool when we're talking about testosterone. Secondly, as I put here, maybe we have to reconsider what a normal dose of transdermal testosterone is in women. I've heard a lot of doctors say the reason I don't use more than 1 milligram or more than 2 milligrams is because of the values that I've seen in the past with saliva. Now, those dosages, if you give them, say, vaginally, where they're on a mucosal membrane, you're going to get pretty big serum values, and you got to watch those dosages. But when you're putting it on the skin, might be something to think about, that maybe what you've considered in the past a high dose maybe isn't quite as high as you've thought. Now, for transdermal estradiol, I would say Dutch is primary. I think serum can be used successfully with patches, but you have to really be careful with creams and gels. Now, we know from the gel data that the value, if you measure various times throughout the day, that value you see in serum seems to correlate with things like increased bone mineral density. But the up and down pattern can be pretty hard to catch with estrogen, particularly with those creams. The only published data shows that it goes up and down in just a couple hours. So if you test 8, 10, 12, 24 hours after dosing, you can really miss pretty much everything that's going on. Urine testing is really nice for transdermal estrogen because it captures it over time, and it seems to scale linearly with dosing. And the values that we see correlate clinically with what's going on in terms of the clinical impact. So I really like Dutch for estrogen. With transdermal progesterone, not enough time to get into it here, but I think the data would suggest that that it's not wise to use transdermal progesterone to balance estrogen replacement therapy. We just can't be assured that there's enough in the endometrium to balance the estrogen. But what we can say pretty convincingly is whether 20 milligrams or 30 milligrams or whatever the dosing is, to get it right, the lab testing really isn't going to be helpful. I would be very cautious about using a lab test to titrate a transdermal progesterone. Now, saliva testing. We do saliva testing. So this whole message I've just given about utility of saliva testing is not just a message for you, it's a message for me. I'm a laboratorian. I love to develop lab tests. So if we saw some unique value in measuring salivary testosterone, value that we weren't seeing elsewhere, if it had clinical correlation that we weren't seeing in either a serum test, which you're going to get at just standard labs, or from our urine-based test, then just like we've done for cortisol, we would develop it because it would be necessary for you to have in your toolbox. To date, I think for those sex hormones, I think we just stick with serum and urine and use the urine for the metabolites. But for saliva, we're going to stick with cortisol, looking at that cortisol awakening response, looking at the diurnal pattern. Saliva is great for cortisol, but for the sex hormones, and especially for hormone replacement therapy monitoring, it doesn't seem to give us the type of data that we want to see that's correlating with clinical utility, but particularly with the creams and gels. So our journey of learning continues. This is not a story that's completely told. There's still new studies coming out all the time. And as it relates to this particular topic, if you know of a study that is omitted from our talk here, I would love to see it because I'm trying to get as comprehensive as I can on understanding that, so that when I bring this data to you, that you can trust that it's up to date and will help you to know where to lean in terms of laboratory assistance for different situations. Feel free to reach out if you have any questions, and thank you for your time.